My topic for today's discussion is regarding conventional angio versus CT angiography. What is the difference between a regular conventional or catheter angio, and what is the what are the pros and cons of a CT coronary angio? What exactly is the difference between the two tests? Where exactly which test should be preferred, and what are the pluses and minuses whenever we are performing a given test over the other? These are the points which we will be discussing, besides the cost and the indications and contraindications of each and every test, and what and in which conditions either of them should be performed. This topic is likely to be very interesting, and I would expect you to continue listening to the video until the end, so that I could give you a lot of interesting and clinically useful information. The people who are new to my channel, I would request them to subscribe to my channel, so that such clinically interesting and valuable content whenever I post on my channel, you would get an instant notification and you could make advantage or use of these topics. जो लोग मेरे चैनल पर हिंदी भाषी हैं, उनके लिए ये कंटेंट ऑलरेडी हिंदी भाषा में अवेलेबल है. इसका लिंक मैं डिस्क्रिप्शन बॉक्स में छोड़ दूंगा. नाउ कमिंग बैक टू द टॉपिक, basically what is angiography and what is CT angiography, this we'll be discussing. Angiography is a test which we perform to see the coronary artery vessels and whether there is any blockage in the coronary vessels. That is the test we do to perform. Usually there are two types of angiography. One is conventional angiography and one is CT angiography. Conventional angiography is done by admitting the patient into the hospital. In fluoroscopy technique, fluoroscopy is a intense beam X-ray radiation which is used in a cath lab, which is the cardiac catheterization laboratory. Here we take the patient and we make the patient to lie down, and by using either the radial or the femoral axis, that is by the hand, which is the radial artery axis, or by the leg, that is the femoral artery axis, we put a sheath into the various extremities, and from the sheath we pass a catheter, which is a thin wired tube, and that tube is passed over a wire across the main vessel into the main vessel, which is known as the aorta, and therein we cannulate the coronary vessels. That is, the coronary vessels are a part of the aorta and are placed in a position or a place known as the coronary sinus. There we cannulate the catheters into the coronary arteries and we inject contrast by means of a catheter, and this contrast is an iodinated material, and this is used to opacify the vessels. Once the radiation beam passes through the contrast, the radiation beam cannot pass the contrast material, and the vessel gets the image of the vessel gets formed on the image intensifier, which is placed on the other side of the radiation beam. In CT coronary angio, the concept is almost similar, but there are some few differences. In CT coronary angio, we do not take an arterial puncture, we do not do it by the hand or leg arteries, rather we do a venous angiogram, usually similar to what is the venous cannula is put to inject saline and other injectable medicines. The same venous cannula is inserted in the patient, in the vein of the patient, and using that vein we use a power injector to inject forcibly the same iodinated contrast, which is almost similar to the contrast which is used in conventional catheter angio. In CT angio, this contrast is injected into the main blood vessel, and the entire aorta and the entire blood vessels gets opacified in this one go, and CT gantry keeps rotating at that point of time, and it takes a multi-dimensional view of the coronary arteries, and this multi-dimensional view which is once taken, that is interpreted by the machine and the image intensifier which captures these images, and this image which is captured by the machine is used to form an image of the coronary vessels, and by seeing this we can interpret whether the patient is having any coronary artery blockages or not. The main difference in the CT and the conventional catheter angio is the technique by which it is done. Conventional catheter angio, as I have discussed, that requires hospital admission and arterial puncture, while CT coronary angio does not require hospital admission and does not require an arterial puncture. So it is, although both of them are invasive, but comparatively conventional catheter angio is more invasive, because here we insert a catheter and that catheter is passed into the coronary vessels, and from we cannulate the coronary vessels and then we inject the contrast. In comparison, in a CT angio, catheter is not taken into the heart, and directly from the venous cannula we inject a contrast forcibly, and that is used to opacify the coronary vessels. So comparatively, if at all you talk about the safety of the patient, conventional catheter angio has slightly more amount of risk, especially in patients where there is critical blockages and multiple blockages in the main vessels or the left main area. In these places, whenever we cannulate the vessel, there are chances of slight damage to the vessel, and 1 in 1000 risk of some adverse events also can occur to the patient whenever we are passing a catheter into the aorta. Some plaque which is present into the main vessel, that can get embolized also whenever it is touched by the catheter. So these are the few risks which are more in a invasive procedure as compared to a non-invasive procedure. In CT coronary angio, the disadvantage is that CT coronary angio involves the use of a larger amount of contrast. In regular catheter angio, we use only 10 to 20 ml of contrast, while in CT coronary angio, we use almost 100 ml of contrast. So the amount of contrast used in a CT coronary angio is on the higher side, and the image quality which is obtained in a CT coronary angio is less reliable as compared to that of a conventional catheter angio. These are the basic differences where a CT angio and a coronary angio are different. Conventional catheter angio is preferred whenever the patient is a high risk, or where we are almost sure that the patient is more likely to have a coronary artery disease. Therein we need the patient to get admitted and we perform a conventional angio, because in this case we need an absolutely certain report whether the patient is having a blockage or not, and if at all the blockage is confirmed, then using the same catheter and wire we can pass a balloon and we can deploy a stent also and treat the patient on the same sitting. While in CT coronary angio, in such cases where the risk is high and the patient is elderly, usually the reports are less reliable, and in these cases, if at all the image does show some coronary artery blockage, the exact specification of the blockages are difficult to be obtained by using a CT coronary angio, and in these cases, whenever the report is doubtful, we need a conventional catheter angio to confirm our findings. So in high risk patients, or in patients where we are more likely to have a coronary artery disease, or in patients where the age of the patient is high and the vessels are more likely to be calcified, in these cases conventional catheter angio is preferred. Also in patients where kidney disease is already present, because as I have told that conventional catheter angio involves much lesser amount of contrast being used, which does usually damage the kidney. That is why in these patients where already the kidney is damaged, we tend to prefer a conventional catheter angio as compared to a CT angio. The CT angio is preferred in very young patients where we use it only as a screening purpose, because the patient is very young and very less likely to have a coronary artery disease. In these cases, the negative predictive value of a CT angio is high. That means if at all the CT coronary angio tells us that the report is normal, then the patient is very less likely to have a significant blockage, and it essentially rules out the presence of a significant coronary artery disease. But if the report comes positive, then it becomes a problem and we need a conventional catheter angio to confirm our findings and plan any strategy of treatment. So the general dictum is that if the patient is having a low risk profile and a very young patient wherein we are using it only to screen whether the patient is having coronary artery disease or not, there we tend to prefer a CT coronary angio. And if at all we need a confirmed diagnosis and we want to plan a treatment where we are almost certain that the patient is having a significant coronary artery disease, or in patients who have a kidney problem, in these patients we tend to prefer a conventional catheter angio, because in these patients we can plan the treatment at the same sitting, because the same catheter can be used for the treatment of the patient as well. Now we come to CT calcium scoring. CT calcium scoring is a much less invasive procedure where we put the patient in a CT scan machine. We do not inject any contrast, and the CT scan machine calculates the amount of calcium which is deposited into the vessel, and by using the intensity of the calcium which is deposited on the vessel, it tells to the operator whether the patient is having a significant coronary artery disease or not. Because with age, most of the coronary artery blockages tend to get more and more calcium deposition, and this calcium deposition can be picked up by a CT scan machine and the image can be demonstrated on the CT machine. So if at all we get a very high calcium score, that suggests that the patient is having significant coronary artery disease, and this finding has to be confirmed later by a CT coronary angio or a conventional catheter angio. If at all the CT calcium scoring is very low, then it is more likely that the patient does not have a significant coronary artery disease, and these are the patients where invasive catheter angio or a confirmatory angio may or may not be done. Although CT calcium scoring is a relatively reliable tool, but in cases where calcification is not much, and especially in very young patients who are more likely to have clots in their coronary arteries and less calcified, more atherosclerotic blockages in their coronary arteries, in these cases the CT coronary calcium scoring, the values can be completely wrong, and we may or may not be able to judge whether the patient is having significant blockage or not. And in this case, the angiography, the CT coronary angio or the conventional catheter angio, gives much better results as compared to a calcium scoring. Calcium scoring is just useful as a screening tool, and that too in very young patients, where we just want to use it as a screening purpose and we do not want to inject contrast. Therein the role of CT calcium scoring is high. But if at all patient is already having some disease, or elderly patient where the vessel is already calcified, in these cases the role of CT calcium scoring is much less. Now, what is a contrast? Basically, contrast is an iodinated material which is contains a material which contains a lot of iodine, and usually it is of multiple types. It is either can be classified into non-ionic or ionic contrast. Non-ionic contrast means is a newer type of a contrast, and in this contrast can be used much more safely in all the patients. The osmotic load on the heart in this type of contrast is much lesser as compared to an ionic contrast, which is slightly an older technology. Although it is, the ionic contrast is cheaper, but it contains a lot of osmotic load for the heart, and sometimes it is slightly bad for the heart and also for the kidney. So these days majority of the guidelines tend to advise the patients to use more of non-ionic contrast as compared to ionic contrast. There is something which is known as the iso-osmolar and non-osmolar contrast. Iso-osmolar contrast means the osmolarity or the thickness of the contrast is exactly the same as that of the blood, while hyperosmolar contrast means that the thickness of the contrast is more as compared to that of the blood. If at all the contrast is iso-osmolar, then the contrast is much less likely to damage the heart and the kidney as compared to a contrast which has a more osmolarity. The hemodynamic burden caused by a hyperosmolar contrast is slightly more as compared to that which is caused by a iso-osmolar contrast. Usually the ionic contrasts have a much higher osmolarity as compared to the non-ionic ones. Usually whenever the contrast is injected, especially ionic contrast, it causes hemodynamically significant overload on the heart, and it can damage the kidney, which is known as the contrast nephropathy. Usually contrast nephropathy is maximally seen on the second, third day after a procedure, and sometimes a very few number of the patient can develop permanent renal damage also, and some very few % of these patients need to go under permanent dialysis also. That is why whenever we are dealing with these contrasts in a patient who has already damaged kidneys, in such patients we should use contrast with much more wise way, and we should take care that the kidney is not damaged. Ideally, there are some medicines which are available to protect the kidneys in such patients, and we also should ensure that the patient is adequately hydrated. That means we give the patient lots of water before and after the procedure to prevent kidney damage. Usually majority of the patients where some amount of kidney damage has occurred because of contrast, usually it recovers spontaneously within few days, but in some patients where the kidney damage is permanent, it doesn't recover spontaneously, and it can take the patient into long-term dialysis also. And in the short run also, some number of patients may require 1 or 2 episodes of dialysis. Later the kidney might spontaneously recover. So contrast nephropathy is an important issue, and contrast induced kidney damage is an important problem which should be taken into care whenever a patient is being taken for a coronary angio, whether it's a CT coronary angio or conventional catheter angio. Both these angios require contrast material. The type of the contrast might be different in either of them. In a patient who is already having a significant kidney problem, we should be using the contrast as minimum as possible. Usually it is said that the lower amount of contrast we use, the better it is for the patient, and we should be hydrating the patients adequately well, and we should be using some medicines also which are available to protect the kidneys in such patient. The purpose of this topic is that I have discussed the difference between conventional catheter angio and a CT catheter angio. A lot of people ask us what is the difference between this test and which exactly are the patients where we should do a CT angio and where exactly we should do a catheter angio, what exactly is the difference, and how do we select our patients for either of these procedures. So in this topic I have discussed these points, and I have also talked about what is the contrast material which is used for these procedures, what is the types of contrast, and how exactly they affect the kidney and affect the heart, and what is exactly the concept of contrast nephropathy. The purpose of my channel is that I like to discuss scientifically correct and useful information, and I wish to make this information easily available for the heart patients so that they can manage their disease well and they can discuss the disease better with their doctors. This information usually is very difficult to access, and most of these people are dependent upon the doctors and their friends and relatives for this information. If at all you like the concept of my channel, I would request you to like my channel, like my videos, and subscribe to my videos. If at all you feel that the content of the videos is relevant and important for your friends and relatives, you can share the link of the videos with them. And if at all you feel that in subsequent videos we should take up some topics and we should discuss a new topic, then you can mention about those topics in the description box below so that we can take up those topics in future videos. So this is Dr. Naveen Agrawal, and I am signing off, thanking you a lot that you have listened to my video up till the end, and I hope that I was able to give you some important and clinically relevant information. Looking forward to seeing you again in my future video, and the people who are new to my channel, I would request them to subscribe to my channel, because that gives us a lot of motivation and strength to keep posting such good videos for you. Thank you.